Welcome to iFormRx, where we explore the evidence that matters to ambulatory care pharmacy practice. Today we'll be discussing the manuscript entitled Pioglitazone After Ischemic Stroke or Transient Ischemic Attack, also known as the IRIS study, published in the New England Journal of Medicine in April 2016. Guiding us today, our moderator, Margaret Micklich, a PGY2 ambulatory care pharmacy practice resident at the University of Maryland School of Pharmacy.
In the United States, ischemic stroke occurs in upwards of 700,000 adults annually, and transient ischemic attacks, or TIAs, are experienced by nearly 250,000 adults each year. Globally, stroke is the second most common cause of death and the third most common cause of disability. After a stroke or TIA, patients are at a high risk for future cardiovascular events, including recurrent stroke as well as myocardial infarction. There are several pharmacologic and non-pharmacologic strategies to prevent these events, but novel and improved approaches are needed. Over the next few minutes, we will review the current guidelines for secondary stroke prevention, examine the design and results of the IRIS study, and, with the help of our expert panelists, discuss the potential role of pioglitazone for the secondary prevention of ischemic events in patients following stroke or TIA. The American Heart Association, in conjunction with the American Stroke Association, publish guidelines for the prevention of stroke in patients with stroke and TIA, most recently updated in 2014. The guideline offers a comprehensive, evidence-based approach to the secondary prevention of stroke and TIA, including recommendations on the use of antiplatelet therapy, as well as recommendations for controlling risk factors such as hypertension, dyslipidemia, obesity, and glucose disorders. It's important to understand the role of glucose management in stroke prevention, given the increasing rates of prediabetes and type 2 diabetes in the United States. Insulin resistance is a very common metabolic defect in patients with abnormal glucose tolerance and diabetes. Even in those who do not have diabetes, the presence of insulin resistance doubles the risk for ischemic stroke. Furthermore, diabetes is associated with an increased risk for both first and recurrent ischemic stroke. In patients with existing cerebrovascular disease, up to 70% have some disorder of glucose metabolism. Many pharmacologic options exist to improve insulin resistance, including pioglitazone, which is a thiazolidinedione, or TZD for short. These drugs act by activating the peroxisome proliferator activated receptor alpha and gamma, or PPAR alpha and gamma, to modulate the transcription of genes, ultimately leading to improvement of insulin sensitivity, lipid and protein metabolism, vascular endothelial function, inflammation, and fat distribution. Pioglitazone's effect on cardiovascular outcomes was previously studied in the PROACTIVE trial. In that study, pioglitazone did not reduce the composite rate of death, myocardial infarction, stroke, acute coronary syndrome, vascular surgery, or amputation. However, pioglitazone did reduce the composite of death, myocardial infarction, or stroke. Based on this, IRIS investigators proposed that pioglitazone might reduce the rate of stroke and myocardial infarction in patients with insulin resistance, but not diabetes. 3,876 patients were included in this randomized, double-blind, placebo-controlled international trial. Patients had to be aged 40 or older, have an ischemic stroke or TIA within the 6 months prior to randomization, and have insulin resistance as defined by the HOMA-IR score of greater than 3. The HOMA-IR, also known as the homeostasis model assessment of insulin resistance, is calculated by multiplying fasting glucose in millimoles per liter by fasting insulin in microunits per milliliter and dividing by 22.5. Since insulin sensitivity can be temporarily impaired after stroke, HOMA-IR screening occurred at least 14 days after the stroke or TIA. Patients were excluded if they had diabetes, a history of intolerance to TZDs, or New York Heart Association Class 3 or 4 heart failure, or Class 2 heart failure with a reduced ejection fraction. During the trial, enrollment criteria were amended to exclude all patients with a history of heart failure, a history of bladder cancer, or those at high risk for bladder cancer. Participants were randomized to receive either pioglitazone or matching placebo. It should be noted that the average time to randomization after index event was about 80 days. Patients in the pioglitazone group were started on a dose of 15 milligrams. If there was no report of new or worsening edema, shortness of breath, myalgia, or excessive weight gain, the pioglitazone dose was increased to 30 milligrams at 4 weeks and 45 milligrams at 8 weeks. Subjects were discontinued from the study if they developed heart failure or bladder cancer, or if patients had 2 low-energy bone fractures. The primary endpoint of the trial was time to first occurrence of stroke or MI. Secondary endpoints included stroke, acute coronary syndrome, onset of diabetes, cognitive decline, all-cause mortality, and a composite of stroke, MI, or heart failure resulting in hospitalization or death. The baseline characteristics of the intervention and control groups were well matched. Mean age was 63.5 years. About 2/3 were male. The majority of study participants were Caucasian, with about 12% being Black and 4% being Hispanic in each group. The median HOMA-IR index scores were similar in the intervention and control groups. About 1/3 of patients had A1C less than 5.7%, over half had prediabetes, and a small percentage had A1C of 6.5 to 6.9%, which we would classify as diabetes today. This study was designed prior to the inclusion of A1C as diagnostic criteria for diabetes. Cholesterol and blood pressure were well controlled and similar at baseline. The majority of patients were receiving appropriate treatments for secondary prevention of stroke, with 82% of patients taking a statin and 92% of patients taking an antiplatelet agent. For the vast majority of patients, the index event was their first cerebrovascular event, but about 13% of patients in both groups had experienced a prior stroke. Overall, patients in both groups experienced mild strokes with minimal disability. The average stroke severity based on the NIH stroke scale score was 0. For this scale, a score under 5 means mild impairment. The average disability score based on the mean modified Rankin scale score was 1 out of a possible 6. A score of 1 corresponds to no significant disability despite symptoms. After a median follow-up of 4.8 years, the primary outcome of stroke or MI occurred in 9% of patients, or 175 of the 1,939 patients in the pioglitazone group, and 11.8% of patients, or 228 of the 1,937 patients in the placebo group. This was a statistically significant outcome with a hazard ratio of 0.76 and a p-value of 0.007. As for the secondary endpoints, the only one achieving statistical significance was the rate of progression to diabetes. Of the 1,937 patients with insulin resistance being treated in the placebo group, 7.7% progressed to diabetes, whereas the rate of progression to diabetes in the pioglitazone group was only 3.8%. The hazard ratio was 0.48, and the p-value was less than 0.001. The other secondary endpoints, stroke, acute coronary syndrome, death from any cause, or composite of stroke, MI, or serious heart failure, did not achieve statistical significance. IRIS also examined safety outcomes. The rate of death, hospitalization, bladder cancer, and heart failure were not statistically different between groups. However, there were 3 statistically significant safety outcomes, none of which come as a surprise, since they are recognized adverse effects of TZDs. Edema occurred at a higher rate in the treatment group, as did weight gain above 4.5 kilograms and weight gain above 13.6 kilograms. Additionally, both serious and non-serious bone fractures occurred more commonly in patients treated with pioglitazone. Serious bone fractures were defined as those requiring surgery or hospitalizations. To paint a quick picture of important clinical and safety outcomes, it would take 100 patients being treated for 5 years to prevent 3 strokes or heart attacks. But of those same 100 patients, 2 would experience serious bone fractures within the same time period. The results of the IRIS trial certainly generates a number of clinically important questions for discussion.
And now, to help us answer these questions, I'd like to introduce our expert panel for the roundtable discussion. Dr. Curtis Tripplett is an associate professor of medicine at the University of Texas Health Science Center at San Antonio. He's a certified diabetes educator and practices as a clinical pharmacy specialist at the Texas Diabetes Institute. Dr. Joel Mars is an associate professor at the University of Colorado Skaggs School of Pharmacy and Pharmaceutical Sciences and is a board-certified pharmacotherapy specialist with added qualifications in cardiology, as well as a board-certified ambulatory care specialist. He currently practices as a clinical pharmacy specialist in adult internal medicine at the Eastside Family Health Center, one of the Denver Health Community Health Clinics. Thank you both so much for joining the iForum RX discussion today.
Thank you so much for having us.
Thanks for inviting us and having us on the call today.
So, what did you think of the results of the study? Were they surprising? Are the results compelling? And what are the major strengths of the study?
Well, first of all, I wouldn't really call them surprising. We already had some data from the past that was showing us that it appears that these class of drugs may decrease the risk of stroke. There was data from the PROACTIVE trial as well as a Cochrane meta-analysis that it kind of told us, I think that these drugs might actually decrease the risk of stroke. So I think we would have actually expected a small reduction in stroke from these drugs. And I think it was a strong study as far as the number of people involved, the length of follow-up. It was a well-managed group of mild post-stroke patients. And I think pioglitazone is a compelling interest for us to consider for patients.
I would agree with a lot of what Curtis highlighted. I think one of the things in regards to the results, I think the major primary endpoint definitely was statistically significant. But I think one of the things that we'll bring up in a little bit is balancing that out with some of the potential harm. I agree there's a number of strengths with this study, and there's a lot of previous trials that kind of led us to believe that there could be a stroke risk reduction with pioglitazone. I think one other major strength to highlight is that it was a large population studied and actually a large population in the U.S. because more than 50% of the individuals in the trial actually were from U.S. sites.
Next, are there any significant weaknesses that challenge the study's internal or external validity?
So I think there's a few issues. So they tried to define this pre-diabetes or at-risk for diabetes population by insulin resistance assessment. And one of the limitations is they actually did enroll patients with a true diagnosis of diabetes, even though a small percent were diabetic. And so that does decrease some of the application of, is it purely just pre-diabetics that would see this benefit versus could this translate into benefit in the diabetic post-stroke population as well?
There's a few things that I saw when I was reading through that kind of piqued my interest in. One of them was the fact that it seems like they only enrolled patients who had a mild stroke. And my fear is that maybe the neurologist kind of had a selection bias and that they really weren't enrolling patients that they felt uncomfortable with. And that's always been one of the problems with pioglitazone, is that people may find some positive outcomes, and of course PROACTIVE, ACT NOW, other trials, Periscope, have shown positive results, but I still think people feel in general uncomfortable. When you kind of look at some of their background, I was a little worried. They said they wanted to get 27% of the placebo group to have an event. They only got about 12%, which is why as you look through the trial, you clearly see they had to extend at least twice recruitment. They also, of course, had many problems with adherence. You see that probably 1 in 4 to 1 in 5 people by the end of 1 year was already off the drug. If you look at the adherence, really it ends up being that people were really on 30 milligrams of pioglitazone a day instead of 45. And there's nothing wrong with that. I mean, 30 milligrams equals about 40 to 60% of the maximal effect, but 45 milligrams certainly is better for not only A1C reduction, but cytokine reduction. And then one thing very worrisome is the HOMA-IR. Inclusion of people only with a HOMA-IR above 3 is really worrisome because it's quite low. So saying that someone has a HOMA-IR of 3 and saying this person is insulin resistant is a little misleading. And they really had problems with their insulin measurements. We've done a lot of measurements with their particular insulin group that they use, which is called the millipore linkoplex. It's not very accurate. They have some kind of equation you have to use to make it equivalent to the ELISA. I wonder about the HOMA-IR and the measurement itself.
Given what we know about the prevalence of stroke, can these results be extrapolated to certain high-risk populations that were not included or underrepresented in the study? For example, would you consider using pioglitazone in someone who had a disabling stroke? Or would you preferentially use pioglitazone in a patient with diabetes who experiences a stroke?
So I don't think that you could extrapolate this data to people with more severe strokes. But I think if you had prediabetes or diabetes, you might consider the drug.
Yeah, I would agree with Curtis that there's pretty limited ability to apply this to a more severe stroke patient population, because how they defined stroke in the study was 95% were at a mild impairment based on the NIH stroke scale, and then even if you looked at the modified Rankin scale, 90% were in the no symptoms or significantly no symptom impairment. And then I agree with their subgroup analysis across the board. There really wasn't anything that stood out that I think can be extrapolated. I wouldn't expect to be less effective in a diabetic population that had a mild stroke based on how the drug works and how they designed this trial. So I would be open to applying that to a mild post-stroke patient that had concurrent diabetes.
Are there any strategies we can use to mitigate the adverse effects associated with pioglitazone? Are there certain populations that you would avoid using pioglitazone in?
Some of these we talked about previous, but so clearly still the class 3 and 4 heart failure patients would be excluded from this trial, as well as you wouldn't want to use pioglitazone on them. In regards to minimizing adverse effects, I think the positive piece in this trial was they excluded heart failure patients at enrollment and didn't necessarily see a difference in heart failure developing between the two groups. Some of the concern was the dramatic amount of weight that we saw in some of the subgroups. And so I think it's just something to be aware of at baseline of, is someone overweight at baseline? Has someone had a history of edema, to try to pre-screen those individuals out from starting pioglitazone? Are they on potentially other agents or medications that would predispose them to have more edema? Are they on a concurrent dihydropyridine calcium channel blocker that would maybe predispose them to developing edema?
I agree with the weight. I mean, there was a lot of weight gain in this particular trial. When 10% of your patients are gaining more than 30 pounds, I think it causes pause for us to really consider whether this drug is right for some people. So important for them to weigh themselves every day. And if they have a large weight gain, they need to call you. Same thing goes for edema. Of course, we know that the edema is from plasma volume and probably sodium reabsorption, and we're going to have to manage that. And in this particular trial, severe edema was seen in almost 20% of the patients, and another 20% shortness of breath. So there was just a lot of side effects that we have to think about for this. For the edema, I mean, we try to limit that through using something that hits the distal tubule, usually spironolactone, and then we add on another diuretic, and it's really up to y'all what you want to add to that. So it could be a thiazide diuretic, or even once you add the spironolactone, sometimes the loop works just fine. And that's anecdotal. That's what we do here at our clinic. We avoid populations such as postmenopausal women because of fractures, Clearly, there's data that shows that it decreases bone mineral density despite an increase in weight. We tend not to use it in smokers and in men who are smokers, especially because of the bladder cancer risk.
In light of our conversation and the discussion of this trial, I would like you to make a prediction. What do you think will be the place in therapy for pioglitazone in the next edition of American Heart Association and American Stroke Association clinical practice guidelines for the secondary prevention of stroke?
So I'm not a stroke expert, but I would actually say that neurologists would feel comfortable including in the guidelines for patients who are pre-diabetes or diabetes to consider adding pioglitazone. I don't think neurologists are going to put anything about HOMA-IR in there. I think that that's something they're going to feel uncomfortable with, and I actually wouldn't use it either.
I think there will be a recommendation funneled into those revised guidelines when they are updated. I think they probably will focus more on that pre-diabetes population as the primary target, but I think they probably will include diabetes as well. They're probably going to fall into more of a class 2 recommendation. This could be a potential means to further reduce overall cardiovascular risk in this population.
Thanks again to Dr. Tripplett and Dr. Mars for their insights and commentary regarding the IRIS trial. In summary, this landmark study suggests that pioglitazone is effective in preventing recurrent vascular events following a non-debilitating stroke or TIA in patients with insulin resistance. However, it comes as no surprise that treating these patients with pioglitazone will increase the risk of edema, weight gain, and bone fractures. What are your thoughts about the IRIS trial? How should the evidence be applied to patient care? We would love to hear your thoughts and welcome your comments. Thanks for listening.
This broadcast is brought to you by iForumRx, exploring the evidence that informs ambulatory care pharmacy practice.